Welcome everyone. So welcome to the 8th session of the Mahamana case discussion series. And today's talk is discussion is on the thyroid cancers. And thyroid is not one small topic that can be covered on a single discussion or a class of 1.5 hours. So we will be focusing on differentiated thyroid cancers today. And for the pre-session, we have Dr. Neeti Kapre Gupta from Neeti Clinics Kanpur. Neeti Clinics Nagpur. And she'll be speaking on differentiated thyroid cancers, workup, and molecular testing.
Hi, good evening, everyone. So differentiated thyroid cancer, as we know, is a favorable biology, but treatment complications can be equally unforgiving. So to maximize outcomes with minimum morbidity, good treatment planning and a thorough workup is of paramount importance. And all of us contenders who want to do just that, we shouldn't be like the 7 blind men looking at the elephant. So we should be actually speaking to each other, have a common dialogue, and maintain a holistic viewpoint. More often than not, it is us surgeons who are the first point of contact for patients with DTC. So we start, of course, with history and clinical exam. Age is such an important prognosticator for DTC that it's actually a part of the staging system. So we know that on one end of the spectrum, pediatric or adolescent thyroid cancers present with more nodal and even lung metastasis at presentation, but they're more radioiodine avid and overall have excellent prognosis. On the other hand, elderly thyroid cancers will be more locally advanced, more extrathyroidal extension, more dedifferentiated cancers, and disease-free survivals will. Radiation-induced papillary thyroid cancer, initially thought to be a distinct clinical entity with more aggressive features. More and more recent literature says that age and stage match disease has actually equivocal outcomes. But again, an important history to elicit. Familial papillary thyroid cancer is an extremely rare entity, but even in the microcarcinoma stage, they tend to be multifocal, so a good treatment is warranted. Coming to symptomatology, more often than not, we're getting this demon of incidentally detected asymptomatic thyroid cancers. And before we go bomb blasting our orthopedic colleagues for ordering these so-called unnecessary MRI cervical spines, let's take a quick look at the algorithm that one should follow when encountered with such incidentallomas. So without any high-risk features, one should order an ultrasound for size evaluation and risk stratification, and then proceed according to the TIRADS grading on whether to needle this nodule or whether to just keep it up. But we do know that PET-detected focal thyroid uptakes have increased chances of malignancy. Almost 1/3 of these will be malignant, majority PTCs. So every PET-detected focal thyroid uptake should be biopsied. When the patient does present with a swelling, rapid increase in size, new development of pain, or of course, compressive and invasive symptoms are clear red flags. One would also evaluate for symptoms of hyperfunctionality on general examination, just a view of the BMI or the body habitus to plan the surgical approach. I will not bore my learned audience with this typical clinical examination criteria. So of course, you'll look for laterality, nodularity, retrosternality, ease of transcervical delivery, etc. These dilated vessels are a telltale sign of retrosternal extension and some SVC compression. And of course, this is a clearly locally advanced, probably dedifferentiated or anaplastic disease. Neck nodes can sometimes play spoilsport. So we had a lady recently who underwent a so-called branchial cyst excision, and lo and behold, HPE was metastasis of papillary thyroid cancer. Retrospectively, she did have an ipsilateral microcarcinoma in the thyroid. So a word of caution for cystic swellings, they could be cystic metastasis from PTC. Laryngopharyngeal examination, again, another OPD exam, which is of paramount importance for thyroid cancer. You look for vocal cord mobility, not just to document it, but also for medical legal purposes. You look for the compression or displacement for the airway. It's actually a good guide for the anesthetist as a visual impression to plan their intubation approach. And of course, you require it for a frank aerodigestive tract invasion. Moving on to imaging. Ultrasound still remains the universal main modality of imaging because it's easily available, it is inexpensive, non-invasive. It is the first imaging investigation often ordered. We are all familiar with the characteristics of malignancy. So solid hypoechoic nodule that is taller than wider, ill-defined margins, ETE, microcal, presence of nodes, vascularity. But it's gratifying to know that more and more universally people are following the standardized reporting protocols. So we have the TIRADS system being followed, which gives us a good correlate with the risk of malignancy to interpret these ultrasound findings much better. There are certain areas where a cross-sectional imaging will have incremental value, and this will be in these following scenarios. So a retrosternal extension, either into the anterior mediastinum or the posterior mediastinum, or very, very rarely an isolated intrathoracic thyroid lesion. But the nerve will be maximally at risk in the type 2B2. So posterior mediastinum, where more than 25% of the posterior portion of the gland insinuates into the tracheoesophageal groove, is one must really counsel regarding a possible neural injury due to praxia, etc. at surgery. For DTCs, CT scan is extremely important to understand the laryngotracheal framework involvement. So we know that the tracheal invasion is graded as per the Shin's classification. Stage 1 is just abutment of outer perichondrium. Stage 2, invasion of cartilage. Stage 3 is elevation or penetration of the tracheal mucosa. And the stage 4 is a frank full thickness intraluminal extension. Now, why is it so important to know this beforehand? Because it helps to plan your surgical approach. So for stage 1, and you could get away with a shave resection. For stage 2 and 3, you would get away with either a wedge or a window partial resection with a primary closure, something like this. But when there is a circumferential resection required with an end-to-end anastomosis, it's important not only to just document that intraluminal invasion, but to measure the number of rings that would need to be sacrificed, what is the distance from carina, what kind of a cervical mobilization of the trachea will be required. And all of this information can be very beautifully acquired from a good cross-sectional imaging. It is, of course, an excellent radiographic roadmap for nodal metastasis as well, especially with a primary disease with the thyroid gland in situ. Mapping of central compartment nodes is often difficult with an ultrasound, and that is where the CT scan has incremental value. So an ultrasound with a CT scan together has much better accuracy rates to map disease in the lateral as well as in the central neck. And this study done by the Randolph group, they showed a benefit for both primary as well as reoperative patients, wherein detection of macroscopic nodal disease that was missed by the ultrasound, but identified by the CT scan, allowed for a correct expansion of surgery in nearly 26% of the patients. So an adequate surgery could be done in 26% of patients just by doing a preoperative CT scan. Again, contrast interfering with RAI is a long gone myth now, because the urinary iodine levels will fall within a month and will not interfere at all with the post-op adjuvant treatment with the radioactive iodine that is planned. MRI will be used more often like a problem-solving modality, whether it is a laryngotracheal cartilage involvement, esophageal involvement, vascular invasion by extensive nodal disease, or sometimes RL involvement by the assessment of effaced tissue in the TO groove, because MRI affords a better soft tissue delineation. PET-CT is not recommended as a part of workup for differentiated thyroid cancer. The rest of the indications are beyond the scope of this talk, but not a part of the preoperative imaging protocol. Again, radioactive iodine scans are a very good tool in the follow-up, and of course, it has therapeutic implications, but again, not a part of workup for a DTC. Coming now to cytopathology. So in the biochemical test, you're of course going to do a thyroid function level. Some surgeons also like to do a calcium or vitamin D3 level to predict post-operative hypocalcemia, or even to build up these levels in the wait period for surgery. ATA 2015 does not recommend routine thyroglobulin estimations in the pre-op period. But just a food for thought, this is a publication which shows that nearly 12% of papillary thyroid cancers are actually non-secretors. So thyroglobulin will not be a useful tumor marker in the post-op period, and this can only be identified if you have a preoperative baseline available, but not routinely recommended. FNAC is, of course, the gold standard pillar of diagnostics as far as thyroid cancers are concerned, and Bethesda grading, along with its correlate risk of malignancy, is something that is followed globally as a standard. But Bethesda 3-4 is probably the eternal gray zone in the diagnosis and workup of a differentiated thyroid cancer. And maybe this is the driving force for evolution of molecular biology to come save the day. Molecular markers, this is just a brief summarized list of the ones available. BRAF is probably the one that is most extensively researched. So we know that it is averagely seen in roughly 45% of papillary thyroid cancers. RAS mutation is seen in the follicular thyroid cancers, or follicular variant of PTC is roughly 30 to 60%. But word of caution, is also seen in adenoma. So it's probably an early mutation event that is happening in the progression to malignancy. Red PTC, also, although a classical marker for medullary thyroid cancers, red PTC1 is seen in papillary, and red PTC3 is specifically seen in radiation-induced papillary cancers. PAX8 PPAR gamma, again seen in follicular or follicular variant of PTCs, but it is not seen in combination with a RAS. So they are probably following two different pathways towards predicting a follicular-derived thyroid malignancy. TERT promoter mutations, we know, predict aggressive DTCs. And microRNA deregulations have also shown to be an important event in the development and progression of a papillary thyroid cancer. Again, like I said, BRAF V600E is probably the most extensively studied mutation in thyroid cancers. In a review of 18 studies, they showed that it is not seen in benign nodules at all. And if a BRAF mutation is positive, there is an upwards of 99% chance of the nodule being malignant. The only pitfall is that it has low sensitivity. So to overcome that, seminal work by Professor Nikiforov and his team, they included a 7-gene mutation panel. So they had BRAF, RAS, RET PTC, and the PAX8 PPAR gamma. And over 1,000 consecutive thyroid FNA samples with indeterminate cytology were studied. The sensitivity unfortunately remained low, but the specificity and negative predictive value were pretty high. Of note, of the 6% who were mutation negative nodules with Bethesda categories 3 or 4, eventually only 2.3% had invasive cancer, and of those, only 0.5% had cancers staged 3 or 4. Now, this led to a flurry of assays being done. But amongst all the available tests, there is something that we say is a rule-in test and a rule-out test. So let's understand what this is. A rule-in test will have high specificity and positive predictive value. So if a rule-in test gives a positive result, that means there are more chances of there being a malignancy, more chances of there being a thyroid cancer. This is helpful for Bethesda 5 because we are tending to operate on these nodules. So we want to rule in, or we want to detect more and more cancer to help our decision to basically do surgery. Whereas the rule out test is the one which has high sensitivity and negative predictive value. So a negative rule out test result rules out the presence of disease. And this is required when you want to obviate doing unnecessary diagnostic surgery. So more applicable for Bethesda categories 3 and 4. Now, if you look at this comparison, we have the available mutation panel. So we have the Thyrogenx, we have Thyroseq, we have Afirma, and we have the 7-gene mutation panel, and we have Rosetta GX, the newest one. If you look at Afirma, it has low specificity for both Bethesda 3 as well as Bethesda 4, but it has very high sensitivity. Reverse, the 7-gene mutation panel has excellent specificity, but it falls dramatically short on the sensitivity. Whereas the Thyroseq, which is gaining popularity, has reasonably good results with the specificity as well as the sensitivity, both in Bethesda 3 and Bethesda 4 categories. Another problem with the Afirma gene expression classifier was that there was a lot of site-to-site variability in its performance. It varied up to 29% for indeterminates and up to 47% with Bethesda 5. So this probably led to the genesis of the recommendation in the ATA, where they say that if molecular testing is intended for clinical use, then only accredited laboratories should be running these tests for quality control. The similar drawback was not seen actually with Thyroseq, because this is a large prospective multi-center study where they saw sensitivity and specificity as high as 94 and 82%. The bottom line is they could obviate unnecessary diagnostic surgery in nearly 60% Bethesda 3 or 4 indeterminate nodules. And roughly 82% of all nodules who had indeterminate cytology on pre-op FNA, we could avoid doing a diagnostic lobectomy with the help of Thyroseq. Now, how did this impact practice? This was an impact of molecular testing on endocrinologist patient decision. So from a previous historical rate of surgery of 74%, it fell drastically to a 7.6%. So one surgery was avoided for every 2 molecular testing done on a thyroid FNA with indeterminate cytology. Having said that, this is still not standard of care, and this is where the evidence rests as of ATA 2015, which is the recommendation or the guideline that we universally follow. Molecular testing may be used to supplement malignancy risk assessment rather than proceeding with straightaway strategy for surveillance or diagnostic surgery. It is still not recommended in pediatric and adolescent thyroid cancers. One cannot end a talk on molecular biology without saying a quick word on the prognostic value of these molecular markers. So we know BRAF in this large meta-analysis of more than 5,000 PTC patients has increased OR for extrathyroidal invasion, lymph node metastasis, advanced stage, and more risk for recurrent or persistent disease. It has shown to be of value in the post-op risk stratification, along with TERT promoter mutations, which is no longer the new kid on the block, but the newer of the two. So again, a meta-analysis which shows that TERT promoter mutations, again, predict more aggressive disease, more nodal mets, more extrathyroidal extension, and poorer clinical outcomes and mortality. Looking at it in the Indian context, we know that overall, the prevalence of a BRAF mutation is much higher in the Southeast Asian cohort. So we have roughly 53% PTCs who have BRAF mutation positive, and yet it has significant correlation with aggressive disease and is probably touted to be responsible for a progression of classical variant PTC to a metastatic or poorly differentiated subtype. Again, a paper from Dr. Krishnamurthy, you're going to be hearing from him later on. Age more than 45 years, positive BRAF mutation, and extrathyroidal extension has the highest risk and the worst disease-free survival outcomes. A recent paper by Dr. Ball et al. Showed that pediatric cancers, however, do not show TERT promoter mutations. Again, TERT is more of a dedifferentiated disease, so the biology will explain that it's not seen in pediatric cancers. Even BRAF has a lower prevalence in pediatric cancers. It, although associated with iodine refractoriness, did not show any association with distant metastasis. So while we're talking on the Indian scenario and concluding my talk, just look at this picture. This was a cost-effective analysis done for molecular testing versus diagnostic lobectomy. Roughly $15,000 to $20,000 for the molecular testing, roughly $40,000 for diagnostic lobectomy, and they showed that molecular testing was more cost-effective. Even if we forget the conversion rate, majority Indian government-funded schemes will allow for the performance of a diagnostic lobectomy in 20,000 rupees. So no surprises that molecular testing is still not standard of care. It's not routinely available in India. There are tertiary center laboratories who are, of course, doing BRAF and TERT promoter mutations for prognostication, but to my knowledge, there is no Indian lab that is doing molecular testing on indeterminate FNA samples. So it is good to have all the knowledge that is present, because molecular biology is the way forward. But coming back to the topic, it was workup of a differentiated thyroid cancer. So I feel that one must look at things in perspective of the population that we are treating. So there is something that goes even beyond the palpable, scannable, and tappable, and that is the patient profile that we are catering to. What is there? What is the distance that the patient will have to travel to seek radioactive iodine treatment? How often is he or she going to be able to do a thyroglobulin estimation? What is the reliability of the patient population for follow-up? It is only when we look at all these aspects, in addition to our investigations, our mementorium, is when I feel we complete the workup. Thank you.
Thank you, Dr. Neeti Kapre, for such an excellent talk. Now moving on to the case discussion. For that, I would like to invite. Thank you, Dr. Neeti Kapre, for the excellent talk. Now we'll move on to the case discussion. For that, I would like to invite on stage, I would like to invite Dr. Prathamesh Pai, who is Professor of Head Neck Surgery at Tata Memorial Hospital, Mumbai. Dr. Arvind Krishnamurthy, who is Professor and Head, Surgical Oncology, Cancer Institute, Chennai. Dr. Gyan Chand, Professor and Head, Endocrine Surgery, SGPGI, Lucknow. And Dr. Saurav Datta, Director and Consultant Head Neck Surgery, Medica Hospital, Kolkata. The case will be presented by Dr. Vidula Mistry, who is a MCH resident at Tata Memorial Hospital, Mumbai. So over to you, Dr. Vidula.
Hi, Arvind. Arvind, you are muted. Yeah, go on with it.
Thank you, sir. Good evening to all. Today, I'll be presenting a case of differentiated thyroid carcinoma. My patient is a 43-year-old lady, resident of West Bengal, a housewife without any comorbidities, without any addictions. She presented with the chief complaint of right-sided neck swelling since last 3 months. Patient was apparently alright around 3 months back when she noticed a small swelling of almond size over right side of the neck. It was insidious in onset. It gradually progressed over last 3 months to the present size. There is no any history of pain associated with the swelling. There is no history of rapid increase in the size of the swelling.
Asim, I think you need to unmute Dr. Gyanchand and Saurav as well, along with Krishnamurti.
Yes, sir.
Yeah, done. Yeah. I was trying to unmute and now it's good. Yeah, go ahead.
Saurav, we can't hear you. Asim.
Yeah, I've unmuted him, sir.
You can't hear Saurav. That'll be a disaster. Gyanchand also we can't hear.
Asim,
Yeah.
can you?
Yes, sir. We can hear you now.
Dr. Gyanchand as well.
Asim, I think I have logged in from two computers because I'm in Shillong and there is horrible net connection. So can you please, means there is another thing, I think, in the name of iPhone or Saurabh, whatever. I just let me check it.
This is fine, sir. This is fine.
Can you hear me?
Yeah, we can hear you. Dr. Gyanchand is not.
He's there.
Is there?
Yeah.
Hello.
Yeah, yes, sir.
Now it is unmute. Yes.
Right.
Thank you, everyone. Thank you, Asim.
Thank you, sir.
Yeah, Vidula, please start.
Yes, sir. So my patient presented with chief complaint of right-sided neck swelling since 3 months. Patient was apparently all right 3 months back when she developed a swelling which was insidious in onset. It was of size of an almond which gradually progressed over 3 months to a present size. There is no history of pain associated with the swelling. There is no history of rapid increase in the size of the swelling. There is no history of difficulty in swallowing, cough while swallowing, breathing difficulty, or change in the voice. There is no history of weight gain, cold intolerance, lethargy, constipation, excessive sleepiness, or there is no history of weight loss, palpitations, irritability, diarrhea, fatigability, excessive sweating, breathlessness on exertion. There is no any history of radiation exposure in past. There is no history of significant medical illness or any surgical intervention done in past. There is no family history of similar illness or there is no any significant illness in the family. Coming to the general examination, patient is conscious, cooperative, well-oriented to time-place person.
Saurav, in the history.
Can you briefly sum it up, doctor? The salient positive finding?
Hello?
Yeah, Vidula, tell us the history, sum up the history.
Sum up the positive findings. And,
So positive findings of examination.
No, of the history.
Yes, sir. She is a 43-year-old lady. She has a chief complaint of a right-sided neck swelling of 3 months duration. It was insidious in onset and it gradually progressed over last 3 months. There is no any significant history which is suggestive of a hyper or hypothyroidism, increase in the size of the swelling, or there is no any feature suggestive of compressive symptoms. There is no significant family history or there is no history of radiation exposure in the past.
So, any thoughts on radiation-induced cancers? I think Niti just briefly mentioned about it.
Sir, radiation-induced cancers, they are mostly papillary carcinoma of thyroid. They are associated with red PTC3 mutation. More likely to be solid variant or diffuse sclerosing variant. They are common in the pediatric age group. They present after usually a time period of 10 to 15 years. So they are more likely to be associated with the lymph node metastasis.
Right. Any specific criteria to call radiation-induced second cancers?
So criteria. Sorry, sir, I did not get the question.
There is, how do you sort of, say that, this particular cancer is a radiation-induced cancer? It may
If
be
the
general.
patient-
It may not be just for thyroid cancers, but in general, in any other part of the body also, you tend to get some sort of secondary cancers secondary to radiation. So is there any sort of, defined criteria to define that this particular cancer has been induced by radiation?
Sorry, sir.
There's something called as a Kahan's criteria that you can possibly read up subsequently and go about it. And can radioactive iodine cause thyroid cancer?
So there is no documented evidence that radioactive iodine can lead to a thyroid cancer.
So can it cause cancers also?
Yes, sir. Most common cancer which can occur because of the radioactive active iodine is leukemia, and other solid cancers like sarcoma or other breast or tissue cancer, they also can occur because of the radioactive iodine.
More of theoretical importance because you mentioned it, so that's why I thought. Any other thoughts from anybody? Ganchan, Saurabh?
Yes. So, does this patient belong to the endemic region? Because
No, sir. She does not belong to endemic region endemic for goiter.
what about the iodized salt intake?
So she uses table salt, which is iodinized.
Yes. So, usually in the thyroid cases, we ask the patient whether she's taking iodized salt or not, and belong to endemic region or not. So, why
Yes,
this is
sir.
important? What kind of cancers are in the endemic region or different from the iodine-rich area or iodine-deficient area?
Sir, in iodine deficient area, multinodular goiters are more prevalent, and follicular carcinoma of thyroid is more common in the multinodular goiter. And the rest of the population, it is papillary CA thyroid, which is common than a follicular CA thyroid.
Okay.
Yeah, she doesn't have any other contributory findings. And anything in the family history also that you specifically asked for with regards to thyroid?
Sir, regarding family history, whether there is a first degree or second degree relatives which are associated, which have thyroid malignancy or any other thyroid illness, or any other cancer, benign disorders which are associated with the familial cancer syndromes.
Anyway, because that will be more theoretical. So in the interest of a practical discussion, I thought because sometimes, in the history, they tend to ask some of these questions. Otherwise, I think if everybody is okay, we can possibly proceed with the meat of the clinical case discussion. Prathamesh?
Yeah, please go ahead.
Yes.
Sure.
Yes.
Go ahead.
Yes, sir. On general examination, patient is conscious, cooperative, well-oriented, to time, place, person. Patient has not grade of 0. Average built, well-nourished, BMI of 26.
You're having an echo from.
I think Saurabh, I think because two devices now, one of it is echoing, I think.
Yeah. I think it will be
So one device is sound off, I think.
No, sir, please log off from that device because of that electrode. Yeah.
Gaurav and his avatar. Huh?
Sir, I'm not.
Saurabh sir was not speaking, so he was echoing.
Just a minute, sir. Yes, sir. I have left. Okay. Okay, sir.
Yeah, Vidula, go on.
Yes. Patient is averagely built, well nourished with BMI of 26. There is no pallor, icterus, clubbing cyanosis or lymphadenopathy. Pulse is 86 per minute, regular. Blood pressure is 120/80, checked in the right arm in supine position. Respiratory system air entry is bilaterally equal, no adventitious breath sounds. Cardiovascular system S1, S2 is normal and no any murmur. Abdomen is soft on palpation. Coming to the local examination, on inspection, there is a right thyroid lobe appears to be enlarged. It is approximately 5 into 4 centimeter. It moves with deglutition. It extends from the thyroid cartilage level to the cricoid level and from midline to the anterior border of sternocleidomastoid. Overlying skin appears normal without any scar. All the inspectory findings are confirmed by palpation. The swelling is non-tender. It is hard in consistency. There is no local rise in the temperature. Getting below the swelling is possible. There are no any obvious cervical lymph nodes which are palpable. Trachea is central. On fiber optic laryngoscopy, bilateral vocal cords are mobile. So to summarize, this is a solitary thyroid nodule with clinically euthyroid status, probably of neoplastic etiology.
So why are you saying this is of neoplastic etiology? What do you mean by that?
So patient has a thyroid swelling which is of recent onset. It is 3 months duration, and secondly, it is progressively increasing in size. On clinical examination, it is hard in consistency. So these features they are pointing towards and it is non-tender. So and these features point towards the neoplastic etiology.
But you said that this patient has no compressive symptoms. Can
Yes,
this be a benign nodule?
yes, sir. It can be benign nodule also. But benign nodule, it is less likely to have hard consistency on palpation.
What about hard cystic nodules? How will you differentiate a thyroiditis kind of a goiter from a malignant goiter?
So thyroiditis, clinically, patient will, depending upon the which type of thyroiditis.
Your mic is on. Purushottam? Yeah, please go.
So patient will have clinical features. They are like fever. There will be initial symptoms, initial toxic symptoms. Then there will be a diffuse enlargement of the gland. If it is a Riddle's thyroiditis, in Riddle's thyroiditis, the gland can be hard. But however, preceding to that, patient will be having the symptoms which are symptoms of tender thyroid swelling, and it involutes over the time period to become hard or diffuse swelling.
Zoom lo ido ಬರ್ತಾ ಇದೆ today.
Can you mute this, please?
You said it right now. There is a differential diagnosis also. No? Sometimes examiners do tend to ask some differential and Riddle's for of all the thyroiditis, and you did mention it. So by neoplastic etiology, you are also including benign also, or how is it like? No, because I just wanted to sort of clarify with you on that.
Yes, most common etiology is benign follicular adenoma. So that also can be a one differential diagnosis.
But in benign follicular adenoma, so your justification for neoplasm was it is rapidly progressive. Forget about benign and adenoma. Is even means in 3 months 5 centimeter nodule. Is it common with even papillary thyroid carcinoma?
So papillary,
so
papillary.
The only
Yes.
justification for you, so the solid thing and what Professor has told that solids means cystic nodule are tensed and these are hurt, and sometimes they are very increases rapidly. So is it very common for most common thyroid cancer or differentiated thyroid cancer? So is it very common for a differentiated thyroid cancer to progress in a such means within 3 months it will become a 5 into 4 centimeter nodule?
Yes, it is less likely for a well-differentiated thyroid cancer to progress in a 3 months duration.
So I think what Sir suggests, but I would definitely recommend that directly saying in this case that it is a neoplastic origin doesn't justify. Better to say thyroid swelling for investigation, and when examiner asked, then I think it probably doesn't matches with a differentiated thyroid cancer history.
Yes, sir.
Agreed.
How do
So
you?
what first investigation would you like to do in this case, or any thyroid swelling? What should be the first investigation?
So first we will do the thyroid function test for the patient.
Okay, and means what according to result, what will be your justification and what further thing will you do? So if you say TSH or normal or high or low, what will be in 3 scenarios? What will be your next step?
Yes, sir. If TSH is low than normal, then we will do the ultrasonography. We will characterize the nodule if TSH is low, and if TSH is raised, then we will go ahead with the USG and USG guided FNSC from the nodule.
If TSH is low, then
So if TSH is low, then we will now to go ahead with the FNSC. We will characterize the nodule with ultrasonography, and if then patient will go for the medical management, and if still TSH is persistently low, then patient can go with the radionuclide scan.
But in this case, say this particular case, if TSH is low, the particular scenario what you described, Dr.
So in this particular case, we can wait. So we will first we will do the USG and characterize the nodule.
you
If
will
it
not
is
first do the thyroid scan.
yes, sir, we will do the thyroid scan. And if there is a cold nodule, then we will we will do FNAC from that cold nodule to see whether there is a malignancy or not.
Vidula, the question
Yes.
was asked is why, what would be your levels of investigation? So you have done your thyroid function test and you found that there is a low TSH. Would
Yes,
you
sir.
then do any other blood investigations to confirm whether this patient is thyrotoxic or is euthyroid still? Following that, would you then do any investigation if to justify treating this patient? If the patient is euthyroid, then what will you do? If the patient is hyperthyroid, what will you do?
Yes, sir. So in case of low TSH, we will do additional blood testing with the anti-thyroid antibodies. So if these antithyroid antibodies are present, then it might be suggestive
Apart
of
from thyroid
thyroiditis.
antibodies, what else will you do? Blood test. You need to know whether this patient is toxic or not. So what other investigations would you like to do to confirm clinical hyperthyroidism versus subclinical?
Sir, free T3, T4 we need to do.
You will do, right? We'll have to do that. So no, generally what happens is most of the guidelines sometimes says that you do TSH as the initial things, but so you'll have to take it all in perspective. Like, so you gave a suggestion that if TSH is low, you would directly go to medical management. So that may not be the case. The point, as Prathamesh was trying to mention, that you trying to confirm it, and of course in this case you've got a 5 into 4 centimeters sort of lesion also, so you'll have to sort of weigh that in mind as well, right?
Yes, sir.
Vidula, what is the probability of having a malignancy if this patient has low TSH and has got raised antibodies?
Sir, in case of raised TSH, according to
Low TSH and
Low
raised
TSH.
antibodies.
sir, in case of low TSH, probability of malignancy is less than 15%. And in case of raised TSH, probability of malignancy in the suspicious nodule, it can go as high as 50%, 40 to 50%.
Is this for all age groups or is it related to pediatric age group or adult?
Sir, it is for the generalized age group with the thyroid nodules, with a suspicious thyroid nodule.
So then would you do an FNAC in this patient versus a pediatric patient having a similar nodule with low TSH?
Yes, sir. In case of pediatric patient, we will do the FNAC, but FNAC we will direct towards the cold nodule after doing a radionuclide scan.
So just to put it to perspective, if you have a low TSH and your patient is a pediatric age group, you have got a 10% probability that you are harboring malignancy. Whereas if it's an adult, the probability is extremely low. It is less than 4%. So just to keep in mind that in a adult age group, if your patient is having hyperthyroidism, it is less likely to harbor malignancy.
Yes, sir.
Yeah, I entirely agree. I think because her number quoted was 15, and I also thought about 4%. That's what somewhere I read sometime back. In adults, hyperthyroid associated cancers with hyperthyroidism in adults, I somewhere read it's 4%, but it's been some long time. I think you guys are youngsters, you keep reading more frequently.
Gyanchand will be dealing more with the entire spectrum. So Gyanchand, comment.
So, like if the TSH is suppressed, then she should go for the radionuclide scan and see whether the entire gland is active or the only nodule is hyperactive. So if the only nodule is hyperactive, that is the high autonomous functioning thyroid nodule. And if the entire gland is active, then you have to rule out the Graves' disease, because sometimes the Graves' disease with some nodules may be there. And in that scenario, you have to go for the thyroid receptor antibodies. So TRAB antibodies you test, and if it is positive for TRAB antibodies, then it is Graves' disease is confirmed. And if the TRAB antibodies are negative, then it may be the hyperfunctioning thyroid and toxic thyrotoxicosis due to the thyroid hyperfunction. And sometimes it may be the toxic multinodular goiter, along with some nodules may be cold and some nodules may be isoactive or same function with the nodules along with the thyroid. So in this patient, you have to, if the thyroid TSH is suppressed, then go for the scan along with the ultrasound. And for the scan, you have to check whether this nodule is active or the entire gland is active and nodule is cold. And if the nodule is cold, then go for the ultrasound and see the suspicious feature. If the suspicious feature is there, then only go for this FNAC. Otherwise, like Image says, that the in toxic nodule, the chances of malignancy is very less, so it is no need to go for the FNAC in these autonomous functioning nodules.
Yes, sir.
Yes.
No. So by and large, they are mostly euthyroid or sort of hyperthyroid in a way. TSH may be slightly okay. That will be the masked majority. More than 95% or 95 to 96% would possibly be in that. Your thyroid functions would be in that range.
Yes, you are right.
Yeah, go ahead. That's enough.
Of neck done for the patient. On the ultrasonography of neck, there is a right-sided thyroid nodule which is well-defined, solid, hypoechoic, 1.4 into 2.4 into 2.9 centimeter, wider than taller. Microcalcifications are present within. No extrathyroidal extension. On elastography, it is hard with asteria grade of 3. An indeterminate node of 4 into 6 centimeter at right level 6, and there are no suspicious lateral neck nodes. Thyroid function test is within normal limit. Fine needle aspiration cytology is consistent with the papillary.
Vidula, go back to the ultrasound. Is this an adequate report for you?
Sir, lateral neck nodes.
No, is this all the information that you require on your ultrasound, or you need something else?
So I think, sir, what sir is asking, you had the entire USG report, and from that you have taken only the important point. You will not put the entire report. Is it a complete USG report for your decision making, or you have missed a lot of things?
Sir, for decision making, whatever the important points are required related to thyroid nodules, those points are taken here. Yes, sir.
So what are those points?
It is there. So where is your comment about other lobe and isthmus and all other things?
Sorry, sir, I did not mention that.
So don't you think that it is required for decision making? There is no these things have no importance.
Yes, sir, it is important.
And even in the right lobe of the thyroid, you have to mention, you just mention about the nodules. What about the other, like it may be multifocal, so other part of the gland it is normal, or it may be there is some other foci of nodule, or
no, sir. Rest of the gland is normal.
So that's why you have to mention the entire ultrasound report.
Yes, sir.
And what about the pyramidal lobe and other part is enlarged or not?
The pyramidal lobe is not mentioned in the ultrasonography report. Okay. And isthmus and opposite lobe is within normal limits, and rest of the right-sided thyroid lobe is within normal limit.
So any mention of thyroids in this also? I think that sort of,
Yes. Although you have mentioned the points, but the thyroid scoring you have not mentioned.
So one is you have not mentioned about the thyroid scoring. You have not mentioned about the nodule, whether it is present, or if it is absent, you have to mention that there is no nodule in the same lobe. This is the only nodule. You have not mentioned about the other lobe and isthmus. So all these things you have missed. Now just tell me one thing. Now the patient has come with only ultrasonography to you, to Tata Memorial Hospital. The patient doesn't have undergone FNAC. So with this report, will you advise an FNAC or not?
Yes, sir, I'll advise FNAC.
Why? Why?
Because this nodule
when in a thyroid nodule, when will you advise FNAC?
Sir, based on thyroid score, based on the thyroids or ATA restratification, If it is a very high risk nodule, then whenever it is more than 1 centimeter, we'll advise for the FNAC. If it is intermediate risk and if it is more than 1.5 centimeter, then we'll advise for the FNAC. And if it is a low risk, then if it is more than 2 centimeter, then we will advise for the FNAC from the nodule.
Very good. So what are the Hydrix features in ultrasound?
So solid hypoechoic, taller than wider, punctate microcalcifications are present, and presence of extrathyroidal extension are the high risk features which are present in the
Vascularity.
Margins, vascularity.
So internal vascularity is important. However, internal vascularity is not taken as a feature in the thyroid scoring system.
Margins?
Margins are irregular margins. Irregular margins is a high risk features, and whenever there is an extrathyroidal extension, it has got a more weightage.
Is there a thyroids for a nodule which is less than a centimeter? If the same nodule is there, which is less than a centimeter.
Yes, sir.
So,
sir.
So is size a criteria in thyroid?
It's a trick question.
So thyroid's high risk cutoff is given as 1 centimeter for the USG.
Right.
So 0.5 centimeter comes in the microcal, like even if it is suspicious, still FNAC will not be advised for this 0.5 centimeter.
So any less than 1 centimeter nodule, whatever happens in the world, you will not go for FNAC. Am I right?
Yeah. Gaurav, I just wanted this to clarify it with everybody. So thyroid does not have size as a criteria. So with the ultrasound, you're not considering size. You are documenting size. So ATA mentions size as a criteria for calling it a low, intermediate, or high risk. So in thyroids, the considerations are the composition, the echogenicity, the shape, margins, and echogenic foci or something like that.
Yes.
So please do not confuse ATA with thyroids. So when you have thyroids, you are going to look at the thyroid criteria and label it as low, benign, or malignant, or highly suspicious. Then you go by the size. Am I getting?
Yeah.
Yes.
And I think just to add, you don't actually define a thyroids for a sub-centimeter nodule. Thyroids were actually defined, I think sometime in 2008 or 9, I think it was described, and then subsequently it has about 3-4 modifications and 3-4 criteria has been there. So most of the definitions or descriptions, it is, or rather applicabilities for nodules which are more than a centimeter, and then of course you have these 4-5 criteria in which you sort of base these things.
Yes, sir.
Please go.
So the FNAC you did, whether it was ultrasound guided or it was blind FNAC, which FNAC you prefer?
So ultrasound guided FNAC.
So it is always ultrasound guided, or?
Sir, ultrasound guided FNAC has got a more yield of the cells is better with the ultrasound guided FNAC. If it is a solid nodule with a cystic nodule with a solid component, then that can be targeted. Posterior nodules are better targeted with the ultrasound. So it should be a ultrasound guided FNAC.
Yes, it should be ultrasound guided. So what are this Bethesda 6 you told? So what are the different Bethesda category Do you remember?
So Bethesda has got 6 categories.
Okay.
So category 1 is non-diagnostic or indeterminate. Bethesda 2 is benign. 3 is ATP of unknown significance. Bethesda 4 is follicular neoplasm. 5 is suspicious of malignancy, and 6 is malignancy.
What is the chance of malignancy in a Bethesda 1?
Sir, in Bethesda 1, chance of malignancy is around 5 to 10%.
And in Bethesda,
Non-diagnostic, right? Non-diagnostic or inadequate. That's the one, right?
Yes, sir.
So then, what is the possibility of malignancy?
So if it is inadequate, if you do a repeat epilepsy, that might yield a better sampling, and that can lead to a increased risk of malignancy.
Right.
What is the percentage? That is asking.
It is 1 to 5%.
It may vary from series to series, you know?
Yes.
So that is the thing. But on an average, I think that's what they describe. But
So
logically, if you see, go ahead.
Yeah.
Yeah, and you also did mention about some 6 millimeter node or something like that. You want to sort of better characterize that node, or you want to do something more about more in the imaging spectrum, or what are your thoughts on that?
Yes, sir. On ultrasonography, that node is, though it is a subcentimetric node, it is described as an indeterminate node with a loss of fatty hilum. So there is a possibility that that can be a metastatic central compartment node. So we'll do a ultrasound guided FNAC from that node also.
So is that your regular practice, or
Medula, would you do a CT scan, or you do continue with an ultrasound, go by the ultrasound features and do an ultrasound guided?
So for this type of swelling, we can go ahead with the ultrasound guided sonography. But if it is a bigger swell, if it is a larger goiter or larger thyroid swelling, then ultrasound will not be sensitive for the central compartment nodes. So in that case, we will go ahead with the CT scan to know better about the central compartment nodes.
So what is the yield with the ultrasound, and what is the yield with ultrasound with CT scan?
Sir, ultrasound for a central compartment node, it has got a good sensitivity provided the thyroid size is small. So it is around 80 to 90%. And in case of larger swelling, then CT is more sensitive than CT has got a 85 to 90% sensitivity for a larger thyroid swelling.
So if your ultrasound is 80 to 85%, then why you need a CT scan?
Sir, we will not go ahead with the CT scan for all the swellings. If the swelling is large and ultrasonography, in that case, if ultrasonography will not be sensitive, so in that case, we will go for the CT scan.
So there are several studies that have shown that an ultrasound is inadequate for commenting on the central compartment. And the yield with the ultrasound is less than 40%. And as you rightly said, larger the swelling, the less the yield. If you combine ultrasound with the CT scan, your yield increases to almost 80 to 85%. So for all probabilities, if you need to investigate the central compartment, you will want to supplement your ultrasound with the CT scan.
Yes.
So in this case, do you want to do a CT scan in this particular?
Sir, in this case, I don't want to do a CT scan. Sir, in this case, there is a solitary thyroid nodule, and USG will yield enough information to guide the treatment decision.
So when
Okay.
would you sort of go ahead with the CT scan? Like,
So patient presents with the pressure symptoms, or if there is a recurrent case, there are multiple lymph nodes which are positive. Swelling is larger if there is a retrosternal extension. Patient is already operated, or there is a recurrence, or if it is a pediatric thyroid case, in those cases, we'll go ahead with the CT scan.
So in small case where you are suspecting malignancy or FNSC proved malignancy, so you don't want to go for CT scan.
Sir, in this case, there is no indication as such to go for the CT scan.
right.
Okay.
Okay.
What next?
What next? Yeah.
So based on history, examination, and investigations, to summarize, she is a 36. This patient is a 43-year-old female. Case of papillary CA thyroid with clinically TNM staging T2N0M0 which is euthyroid and without any pressure symptoms.
Hello.
So
Yeah.
how will you proceed? What will be your treatment plan? for
देख
this
लो केक ये तो खाएगा नहीं.
Sir, I'll plan a surgery for this patient.
What is the risk stratification for this patient? What is the TNF staging?
Sir, TNM staging is clinically C T2N0M0 stage 2.
So what is the risk stratification?
Sir, risk stratification, this patient will come in low risk as per ATA 2009.
Achha, the patient, you will go for surgery, and for pre-surgical workup, you did a chest X-ray. In the chest X-ray, it has come that multiple shadow in the lungs suggestive of metastasis. You did a CT scan, confirmed. What for this patient? What will be the stage of the disease?
Sir, it will be stage 2.
Okay.
No, CT2N0M0 for this lady is what stage?
It's stage 1.
Stage 1. Huh? You mentioned 2, that's why.
Sorry, sir, it is stage 1, and in presence of metastasis, it will be stage 2.
Right.
Okay. So, what will be your surgery? Means extent of surgery?
Sir, I'll go for the total thyroidectomy with ipsilateral central compartment clearance, and if that comes positive, then we'll go for the opposite central compartment.
So, so tell me, what is the means? Why total thyroidectomy?
Sir, total thyroidectomy, because this patient is a case of a FNAC proven papillary carcinoma of thyroid. So actually, there are many proponents as well as opponents for the total thyroidectomy. However, if this is a case of a proven papillary carcinoma of thyroid, so post-operatively, serum thyroglobulin estimation and during follow-up, it will become easier. If in post-operative period, based on histopathology reporting, if patient risk stratification upstages, so in that case, patient will need a radioiodine, and dose requirement will be lesser for the patient.
So for
And
so for all your cases, for any papillary thyroid carcinoma, you will suggest only total thyroidectomy. From your And sir, I'm getting that point that any papillary thyroid carcinoma, the only treatment option is total thyroidectomy. Am I right?
No, sir. Actually,
In this case, you told that total thyroidectomy, that I can agree that it's only, but what is the reason? I am asking that.
Sir, in this case, total thyroidectomy, because on ultrasonography, there is a indeterminate node in the central compartment.
Okay,
So there is
but you answered that it is a papillary thyroid carcinoma. For that reason, I want to go ahead with total thyroidectomy to it. So if the node was not there, in the ultrasound, they said that there is no suspicious node in central or lateral compartment. In the same case, all other features are same. So what would be your treatment options?
Sir, in that case, we can go with the lobectomy. I'll discuss treatment option with the patient. That there is a that it can be a hemithyroidectomy versus a total thyroidectomy. If after hemithyroidectomy, there can be a possibility of a completion thyroidectomy, and in I'll discuss all the pros and cons for both the surgeries. And at the end, it will be at the patient disposition of the surgery.
Can we simply observe this patient and we do not do any surgery?
Sir, this case particularly, we can observe also, but the size criteria, it does not fit into the criteria for the observation.
No, you just answer in this case whether you will observe or not. You said that I can observe as well. So whether you will observe or observation not possible, this is the first question.
Sir, this case, I'll not observe the patient.
Why?
So because the duration, the clinical features with which patient presented, so it is a short duration.
So only because of short duration you will not observe. No other reason.
What are the you call this as low risk?
Yes, sir.
You call
Yes,
this as
sir.
low risk.
Low
So
risk,
in a
yes.
low risk patient, when you are talking of active surveillance, what are the indications for active surveillance?
Sir, indications for active surveillance, they are divided as indications as per tumor factors, as per patient factors, and as per the treating physician factors. So they are categorized into ideal, appropriate, and inappropriate. So ideally, if there is a multidisciplinary team which is available and patient is well explained and well motivated for the follow-up, patient who is elderly with a small elderly with a less than 1 to 1.5 centimeter nodule, nodule which is well in the center and it is surrounded by the surrounded all over by the normal thyroid parenchyma. So these nodules can be, these nodules are the ideal for the observation. So
does your case matches with the size criteria?
No, sir, it does not match with the size criteria.
So then why in the first go you are not saying that it doesn't matches with the size criteria? There is a suspicious node.
Yes, sir, there is. I told that, sir.
You told about the short duration.
Sorry, go on again.
Sometimes if you are quite emphatic in your answer, no, like I would not offer for this patient, then I guess no, the examiners might move on. Otherwise, a lot of they would start grilling you about the concepts of this. No, so you know it all. It's just that you sort of were trying to sort of give the less preferred answer first and then subsequently. So that's the only thing.
And that you told about the duration, like this patient noticed that swelling. That doesn't mean it was not present before. So incidentally, she might notice, or somebody else told that there is nodule inside your neck, and then suddenly she find there is some swelling. Because after the noticing, it not increasing in size. It was stationary, moving with deglutition, and not it was not fixed to the surrounding structure. All these things. So noticing is different thing, and then present from the swelling in the neck, the duration is different. So it might be present from longer time, but incidentally she might notice.
Yes,
Or
sir.
sometime it was incidentally detected by some physician. She went for some other examination, and they examine the neck and they find there was some nodules in the neck. Or some relatives find, or she might stand in front of mirror and suddenly she find there is nodule in the neck. So that doesn't mean that this nodule was not present from longer duration. So do
Yes.
not emphasize on this until unless it is progressively increasing in size or progressively present with some symptoms like change in voice or pain in the neck or something like that, compressive symptoms.
Yes, sir.
Yeah,
Okay.
and to come to the extent of surgery, I think Saurav did mention there's some 88 2015. It just gives you some sort of leeway in case that node was not significant in the central compartment with regards to the extent of the surgery. So, any thoughts on that? You did mention it briefly, but
Sir, in papillary carcinoma, papillary CA thyroid, there is very high risk of presence of occult nodal metastasis. And here in this case, in this patient, there is already a indeterminate node which is present in the central compartment.
right.
So for this patient, at least ipsilateral central compartment clearance is needed.
There is asking that means if there was no node, okay. So what
Yes.
was in favor of your means there were two options. Am I right?
Yes.
So
Yes, sir.
if less than 1 centimeter, you will go for him. 1 to 4 within means there should not be any other significant factor like ET, nodal mates, distant mate, etc. 1 to 4, both the option, 4 total. So sir is asking that what will be when you will discuss with the patients, what will be your what will be in favor of your hemithyroidectomy things and what will be in favor of your total thyroidectomy thing? Because you have to discuss with the patient in detail.
Vidula, what is your counseling for this patient? You said you will be exploring the ipsilateral central compartment. Now you have the possibility of having a frozen section, and that's the reason you are considering a patient for a total thyroidectomy. Suppose you didn't have the facility for frozen section. What would be your treatment plan? And that's what Saurav is asking you. If you have a patient with T2N0 as your staging, in a 43-year-old, what would be your treatment plan? Vidula? I think she is disconnected.
She's there.
Komal,
Are you there?
Komal, please call her.
Yes, sir.
Okay. So please, you just counsel the patient the advantage of lobectomy and complications of total thyroidectomy. You can just describe to the patient. So what are the worries about this? If you do the total thyroidectomy, patient may go under some complication or advantage you already described before, that what is the advantage of total thyroidectomy in this scenario. So what are the disadvantages of total thyroidectomy? If you do the total thyroidectomy, or pro for the lobectomy?
Gyanchand, I think she has just gone offline.
Okay.
There's a question in the chat box. Why should we not advise a CT scan? Any comments? Would you all do a CT scan, or what? Would you just depend on an ultrasound?
Yeah, if there is no, if the margins are well defined, and like in this patient, the margins were, there was no extrathyroidal invasion, only microcalcification was there, and a small nodule not fixed to the surrounding structure, and there was no lymph node. If the lymph node is not present on the ultrasound, then you can go ahead with the ultrasound only. But if there is some margins are irregular, or if you are on clinical examination, if it is fixed to the surrounding structure, or there is some nodule, there was some thyroid node, lymph node present, which may be maintained high lum, it says in the ultrasound. So in that scenario, you can go for the CT scan to check whether it is really extrathyroidal invasion is there or not. Because sometimes if the tumor is near to the trachea, so it is difficult to delineate because of the air shadow of the trachea. So posterior nodules are difficult. So in some scenario, you can definitely go for the CT scan. But in this patient, you may avoid, you can directly go for the surgery or definitive treatment without doing the CT scan.
So Gyanchan, you are doing your CT scan based on the location of the nodule, the characteristics of the nodule, and possibility to gain more information regarding the involvement of surrounding structures. Arvind, what are your criteria for doing CT?
Generally, say T1 or T2, if the ultrasound is clinically sort of mobile, you don't sort of have any signs in clinically and of imaging of any fixity, and the nodes are good, we don't do a CT scan.
Right. So I think a lot of people will not do a CT scan, but there is those who are more inclined towards doing a central compartment clearance at the first instance of proceeding with a total thyroidectomy. If there are nodal involvements, even micrometastasis, in those cases, they gain additional information with the CT scan about the lymph nodes, and in those cases, you might be benefited. So apart from the characteristics of nodules and involvement of surrounding structures, I think more weightage today is on possibility of the nodal disease being seen, which is not usually seen on ultrasound or may not be palpable. So I think it all depends on the philosophy that you practice. Today, most people are inclined to go central compartment clearance, and in high volume centers where the incidence of hyperparathyroidism and little angina palsy rates are low, they will be more inclined to do a central compartment. So I guess the house is divided. There are people who will do a CT and there are who will not. But I guess we'll also have to depend on the characteristic of the nodule, as Gyan said.
And sir, one more thing I would say that everyone doesn't have the opportunity to have radiologists like Tata Memorial or ADR or SGPGI. In that scenario, surgeon they prefer, or they can interpret CT scan much better than USG and all. So for that reason also, sometimes we prefer to have a CT scan, and also a central compartment. We really think that a CT is much better to see the central compartment, especially if it is a low central compartment nodes.
Okay.
But a little bit, sir, there is some, I am disagree about, because if you go for the CT scan in the periphery, the quality of the CT scan is as much poor. But that's why the good radiologist is required, whether it is ultrasound or CT scan. Even if the CT scan of the periphery, they go for the big cuts, so they may miss some lymph nodes, or they may miss some local invasion and all these things. So good quality of CT scan is as much important as the good quality of ultrasound.
Right. I agree. But today, with the new quality CT scans, and I mean, amongst the surgeons who are now trained to do thyroid and all, our reading of the scans is slightly better than the average radiologist.
Definitely.
So I think you would be able to discern and look at these scans a little more critically in comparison to when we were not trained. So I guess CT scan would be a good modality if you don't have a good radiology department to depend on.
Yes.
There is a question, if I may ask the panel, what is in a patient who is Bethesda 4 and there are the cells which are follicular in origin, what would be your treatment of choice? Would you do a hemi or a total thyroidectomy?
Sir, it depends upon
follicular with Hurtle cells.
If it is a size is less than 4 centimeter, probably diagnostic. If it comes as a thyroid, means what I can say that if it comes as a means with a consent for completion thyroidectomy later on, if it comes as a malignancy. But if it is a large 6 centimeter, 7 centimeter, then we may consider total.
Yes.
Yeah, I think we have to prove malignancy. The malignancy has not been proved, so I guess we'll have to, unless of course Saurabh said the size criteria. But I think we need more information. We need the information on the size. We need information on the thyroids, and then we'll accordingly.
Sir, I would like to add, when we are on a FNAC, when we are having a follicular lesions along with Hurtle cells seen. So in the Bethesda grading, in the previous Bethesda grading that was made, the first one, they had said that as compared to Bethesda category 4, they have higher incidence of developing a malignancy. So if Bethesda 4 is having 15 to 20%, with Hurtle cell, it becomes up to 35%.
So yeah, so the inclination in Bethesda 4 would be more to do with some form of surgery. The extent of surgery was what was sort of being discussed, especially. You're right, exactly.
Sir, one question I would like to ask all of you, that in your practice, whenever for 1 to 4 centimeter, even for a 1.5 centimeter nodule, when you discuss with the patients, what is their majority opt for what, total or hemi?
Arvind?
No, I think sense like a lot of times it's just the physician bias that's actually pushed on the patients, and I know that the data of the 1 to 4 centimeters came from from retrospective data in which about 80% of the surgeons would eventually have done a total thyroidectomy. So I would be slightly more inclined to do a total thyroidectomy, especially if it's more than say 2.5, 3, or hovering around that range. But if it is slightly on the lesser side of just 1.5, 2, and of course if it is fitting into all the other favorable criteria that has been described, then possibly you may sort of advise. So that will be my sort of a bias. But of course, it's your duty to sort of inform the patients that this option is always there. That's how I would possibly go about the clinical.
Question, Neeti?
So I actually wanted to clarify the point where we said that 6 centimeter follicular neoplasm will do a total thyroidectomy. I wasn't clear on that. Why does 6 centimeter push us to do a total thyroidectomy instead of a lobectomy?
No, I
for
guess
a follicular neoplasia.
I think it was not about 6 centimeters. It was only about Bethesda 4 with Hurtle cells and anisocytosis.
So, but having said that, if the other lobe is perfectly normal, would lobectomy?
Niti, if you see, it's I totally agree with you that it's not the size criteria, but if you see the guidelines, they suggest for Bethesda 4 with more than 4 centimeter, all guidelines suggest to go total thyroidectomy. But I means at least ATA suggest. But I agree that you can go ahead with hemi, and after that you can go for total.
Especially the contralateral lobe is normal. What you said.
Counseling the patient better. So what happens is that many times we end up doing total thyroidectomy for other considerations, because either the patient cannot afford a second surgery, or we cannot, the patient says he doesn't want to take any risk, or you find that the patient is already subclinically hypothyroid and will run the risk of being a total hypothyroid post-op and will end up anyway having to take replacement. So there are a lot of other considerations wherein you would want to consider total thyroidectomy. And if the patient is, of course, willing, and the patient is clinically euthyroid, patient is affording, you can, and is willing for another surgery, those cases you will definitely do a hemi, because you do not know whether you're dealing with a follicular cancer or it's an adenoma. So I agree. It also depends on the way patient is counseled and what patient actually desires. I think Vidula come back.
Saurabh's question a little further, if I may, to the panel. What percentage of your patients with this 1 to 4 centimeter differentiated thyroid cancer, after a good informed counseling, opt for a hemithyroidectomy?
My personal experience, very low. Just last week, one of the paramedical student who is working in a medical college came to me with 1.5 centimeter. I almost took 1 hour to convince them for hemi. I gave both the option and I said hemi is good enough for him. Also, he can go for total. He said that I will discuss, and then he has discussed with lot of doctors, and he came and no, I want total only. So majority opt for total, except there are patients like few females, younger patients, they sometimes opt for hemi. But again, the percentage is low in my experience. That's why I asked seniors.
So I think it's all about conviction and convincing. So if you are convinced yourself, you will then convince.
Answer to this question is like, the quality of pathologist is also important, because if it is turned out to be malignant, the most of the time it is papillary thyroid cancer. So it should be the quality of pathologist who is reporting. We have to be considered those also, that they are, especially the thyroid cytopathologist, that they are reporting the FNAC report of the thyroid, because the thyroid FNAC reporting is sometimes very difficult, and whosoever is not frequently reporting, they might report the quality of reporting is not as efficient as we are finding in our institute and other, like your high volume centers.
So Vidula has come back. I think we can direct all the questions to her now.
Yes.
So Vidula, can you tell us why this? What are the other risk stratifications that you know of?
Sir, risk stratification, for the initial risk stratification, there is ATA risk stratification 2009. Then other like Masses by Mayo Clinic, Games by MSKCC. Then there is a British Thyroid Association. So these are the initial risk stratification. And in post-operative and after initial therapy, in post-operative period, there is a modified risk stratification which is used, which is based on the response to initial therapy and the post-operative thyroglobulin and ultrasonography features in the post-operative period.
Okay. So what is the ATA risk stratification based on?
Sir, ATA risk stratification, it is clinico-radiological. It is low risk, intermediate risk, and high risk. So in low risk, it is intrathyroidal papillary CA thyroid. Intrathyroidal papillary CA thyroid with no clinical nodes. On pathological examination, if there are, if it is PT1, PN1, then nodes less than 5 and less than 2 millimeters. And encapsulated follicular variant of papillary CA thyroid and minimally invasive follicular CA thyroid. This comes in the low risk. In the intermediate risk, all the high risk variants of papillary CA thyroid, clinically positive lymph node metastasis, pathological positive lymph node metastasis, if it is more than 5 in number and less than 3 centimeters. So they come in the intermediate risk, and in high risk, presence of distant metastasis, gross thyroid extrathyroidal extension, more than 5 nodes which are more than 3 centimeters, and widely invasive follicular CA thyroid. These come in the high risk ATA category.
Okay. So what is age criteria, and why is the age criteria moved from 45 to 55?
Sir, age criteria initially it was less than 45 or greater than 45. In the recent TNM staging, it has changed to the less than 55 or more than 55. It is based on studies by Jonglas and Nixon et al., where they have seen that on the conditional partitioning of the as per age of the patient, they have seen that there is a change in the overall survival at the cutoff of 55 for the M0 patients. Overall risk of death, it is less when patient is less than 55 years, and in M plus patient, when patient is 55 or more, the risk of death is more. So based on these studies this cutoff was changed to 55, and after changing this cutoff at the 55, this restratification, it became like 99% for stage 1 and 74% for stage 4. So there was this risk of overall survival, risk of death or recurrence, it was it could be it was redistributed in the stage 1 to stage 4. So this was changed from 45 to 55.
Oh, what is the sort of, what does TNM indicate and what does ATA signify? No, so the age cutoff was for recurrence or was it for survival?
Sir, survival. It was for the initial risk stratification.
So risk stratification denotes what, and TNM denotes what? Because age cutoff comes under the TNM classification. Age does not come under the ATA risk stratification, right?
Yes, sir.
So the age.
It is.
Yeah, go ahead.
Yeah. So it is the risk of death on these stages.
So the outcome is disease-free survival or your overall survival. So that is why the cutoff has been increased from 45 to 55.
Yes, sir.
So if you're doing a total thyroidectomy for this as you have planned, what is the incidence of hyperparathyroidism and recurrent langular palsy? Is there any
it is less than 2%.
So in all hands, it will be less than 2%.
Sir,
what is the incidence of permanent and temporary hypoparathyroidism?
Sir, temporary hypoparathyroidism, it ranges from 5 to 20%, and permanent hypoparathyroidism, it is 1 to 2%.
And recurrent laryngeal?
Sir, recurrent laryngeal now, temporary, it is around, actually this temporary paralysis of the recurrent laryngeal now, it depends as per the surgeon's experience also. So there is a varied range. So in general, it ranges from around 10 to 20%, and permanent is less than 2%.
I think temporary palsy rates you are quoting slightly higher, and temporary hypoparathyroidism you are quoting slightly lower. Because the ranges, if you see, there are even incidents of 80% of hypoparathyroidism, but I think in most study it's between up to 30 to 40%, means 6 to 40%, something like that. What do you say, sir?
Yes, sir.
Will you use intraoperative nerve monitoring when you do total thyroidectomy?
Madhula, will you use intraoperative nerve monitor for this
Sorry.
case?
So this case, so this case there is a no as such requirement for the intraoperative nerve monitoring.
So what are the indications for intraoperative nerve monitoring?
Sir, in a difficult cases like a recurrent case or a recurrent case or a extensive invasion or an advanced thyroid involving the tracheoesophageal groove. So in that cases, we will use the intraoperative nerve monitoring.
What else? So you'll do intraoperative nerve monitoring when there is a risk involved in damaging the nerve, especially the contralateral nerve as well. So if you are a low risk, low volume surgeon, if you are doing recurrent thyroid disease or you're doing a redo thyroidectomy, in those cases, you will want to consider doing intraoperative nerve monitoring as a mandatory. If you have a ipsilateral cord palsy and you are going to contemplate a contralateral thyroid lobe dissection, you will want to consider doing intraoperative nerve monitoring. So these are today the considerations for doing intraoperative nerve monitoring. So you said rightly that you will not consider it in this patient. So what is the advantage of using intraoperative nerve monitoring in regards to what Saurav said, temporary nerve palsy and a permanent nerve palsy?
Sir, IONM intraoperatively, it gives you the idea whether which side, when you operate one side, whether the nerve signal is present at the end of surgery on that side or not. So
Right.
you can decide on how much to handle. Yes, sir. How much to handle the nerve on the opposite side. So it reduces the chances of bilateral cord paralysis.
So it reduces the incidence of temporary nerve palsy and not the permanent nerve palsy rates. So that is the fallacy of intraoperative nerve monitoring, and that is why people are moving on to continuous nerve monitoring.
So if you are not using intraoperative neuromonitoring, so how will you identify the nerve? Where should you look for?
So we will use the anatomical landmarks to identify the nerve. For recurrent laryngeal, yes, sir. It is a Beer's triangle, which is inverted right angle triangle, which is formed by the internal carotid, common carotid, internal thyroid artery, and one arm is itself is formed by the recurrent laryngeal nerve. Secondly, we can search for the nerve in the tracheoesophageal groove. seeing the cricothyroid at the base point and at the entry point where it enters the larynx below the cricopharyngeal muscle.
So you are operating a case on the right side, and you searched it in the tracheoesophageal groove, in the Beer's angle, you are not been able to identify. Then where will you search? What is the most constant point?
So we will search the nerve at the entry point. Laryngeal entry point at the cricopharyngeal, where it enters below the cricopharyngeal muscle.
Excellent. What is the incidence of non-recurrent?
So it is 0.5 to 1%.
So in this case, after
yeah, go on.
In this case, after total thyroidectomy and central compartment, the report has come as 2.7 centimeter with no node positive central compartment nodes, and with one node in the central compartment, micrometastasis, and no extrathyroidal micro extension, whether it is microscopic or whether it is. So what will be the ATA risk category, and what will be your further treatment?
Sir, based on the HPR, the patient will come in the low risk category.
There is node positive
So plan
with
will be
micrometastasis. One node with micrometastasis.
Yes, sir. Yes, sir. One node with micrometastasis, it will come in the low risk category, PN1, whenever it is less than 2 millimeter.
So up to how many nodes it's low risk?
Sir, less than equal to 5 nodes, and low, which are less than 2 millimeters.
So what will you suggest for these patients? Any treatment, any further treatment, or nothing?
Sir, we will observe this patient and we'll do the follow-up with serum thyroglobulin, with ultrasonography, and serum TSH.
So when will you do the serum thyroglobulin?
Sir, serum thyroglobulin we will do after.
Would you do stimulated or unstimulated, and what else do you do along with the serum thyroglobulin? In this patient, no? The low risk in which Saurav had given the histopathology.
Sir, if patient is going, if patient goes for the radioiodine scan, then that will be the unstimulated thyroglobulin. Otherwise, it will be the stimulated thyroglobulin, which we will check.
Pardon, come again.
It is other way right. It is other way around. If the patient
other way around.
Yes.
So, how can you get a? Is there any other way in which you can get a stimulated thyroglobulin level?
Sir, recombinant TSH can be given.
So, what is your indication to use a stimulated thyroglobulin level, or would you recommend a stimulated thyroglobulin level for this patient?
Sir, if patient is, if we are planning to do a radioiodine scan for the patient, then in that case only. Otherwise, routinely we will check.
So routinely you use unstimulated thyroid. So how would you follow up? Like, that's what in this particular patient, it's ATA low risk. So when would you do the serum thyroglobulin, and would you do it unstimulated only?
Sir, on initial, we will do the unstimulated only in initial period. And if there is any increase, or if there is any UHG abnormalities,
what is your cutoff?
Then we will go ahead.
No, immediately post surgery, you don't do USG, right?
Yes, sir.
So when do you, in your normal follow-up for this patient, say supposing you're discharging this patient today and your first follow-up, maybe after a week's time, the patient comes to you with this histopathology report. So when do you do the serum thyroglobulin, and what is your sort of what is the information that you would sort of want to know for her to follow up or otherwise?
Sir, thyroglobulin we will do after 2 to 3 months only, not immediately in the post-operative period.
So how will you know that she's in the low risk then? Without the serum thyroglobulin, can you risk stratify her?
So this will be just the initial risk stratification.
Right. Yeah,
And
come. I'll just...
during follow-up, you can change.
So risk stratification is dynamic.
Yes, sir.
Okay, guys, I think we are going to stop now. I would like you all to grade her as to how she's done in the exam, and then we'll wind up. Your comments. Saurabh?
She's good in something. She has to, when she knows all the answer, but sometimes she is just a little bit hesitant to give direct answer like, yes, I will not do, yes, I will do. So that is the only thing, but she's really well read. And I think just 1-2 practices, she will do excellent in exam.
Gyanchan?
Yeah, he's well presented and well read. And so somewhere it is little bit confused. So we had to be clear idea like when to operate, when to not operate, and extent, especially the extent of surgery. So all those you, but due to some confusion or maybe hesitant, she might not come out. So otherwise she is good, presented well, and knowledge is good. Thank you.
Thank you, sir.
Arvind?
Yeah, same. I think good presentation, and she knows it all. No, it's just a question of giving the correct answer in that particular sequence. And I think that comes with practice, and that I'm sure that she'll excel.
I think that she needs more clarity of thought. Maybe needs to be more focused on in her answers. You need to actually consider what the question is and then answer appropriately, because sometimes you might put in it, and you tended to do that today. So I guess you need to practice more, like Arvind said, and focus on the answers. Thank you very much.
Yes. Thank you, sir.
Thank you.
Good evening, everyone. Thank you, Vidula, for the case presentation. I would request the examiner panel that we have today, if they would like to add any more points to today's discussion. Prathamesh sir, Arvind sir, Saurabh sir, Gyan sir.
I guess also discussing the early thyroid cancers, and I guess it was discussed optimally, but of course we'll always fall short of time. There's lots more to discuss in this as well. So maybe in the next few case presentations, you all can ask the other panelists to bring out the points related to the ones that we have not discussed so far. The meta-analysis in central compartment, the meta-analysis for intraoperative no monitoring. Those are the things that will be more need to be discussed more, I guess.
Yes.
I would like to thank all the examiners. Sorry, sir. Sorry.
Gyanchan was saying something?
Yes, sir.
Gyanchan?
Yeah, a little bit about the intraoperative, like we discuss about the nerve monitoring. We can discuss about the parathyroid, how to save the parathyroid, how to identify the parathyroid, because these two complications are more. So we have to discuss a little bit about parathyroid. But due to the shortage of time, so we could not able to discuss. Thank you.
Thank you, sir. We shall have further case presentations on thyroid in the future beyond today. And I would like to thank the esteemed panel that we had today, Dr. Prathamesh Pai sir, Dr. Arvind Krishnamurthy sir, Dr. Kyanchan sir, and Dr. Saurav Datta sir. I thank Dr. Neeti Kapre-Gupta ma'am for today's talk on differentiated thyroid cancer workup and the molecular testing. Thank Vidula again for the case presentation. We had an exhaustive and thorough discussion today, and with a lot of positive discussion, I would say. And the next case discussion will be on the 7th of April 2022, which will be on maxillary tumors. We shall have further sessions on thyroid in the future that we shall plan. And also these sessions are recorded and are available under Mahamana case discussion series on YouTube. So anyone who wants to review these or have missed these sessions today or in the past can do so. Thank you very much for today's session. With this, we conclude today's day. Thank you.
Thank you, Neeti, for that excellent presentation. And it's always a pleasure to hear you. And always.
Neeti always rocks.
Thank you.
Thank you.
Thank you so much.
Thank you, sir.